Hi everyone, welcome and thank you
Hi.
for joining us today for this webinar. Uh, it's part of the series where we're trying to demystify organ donation and transplantation in Kenya. And it's our second webinar. The first time we highlighted liver and kidney donation and transplant, where we had patients of the same talk about the experience, and we also had a kidney specialist who doubled to explain about liver and kidney disease. And today we're doing cornea. We are doing cornea transplant, donation and transplant. We have a patient and a specialist on board from Lions Site First Hospital. So we're going to start. I'll call the panelists and the organizers, starting with Joe Abwako, who is the CEO of Transplanted Kenya. And then we'll have Stephen representing the Lions Site First Hospital. And then we'll have Chris Mwangala, who's the cornea retrieval specialist from the hospital. And then we'll have Timothy Mbuthia, who is the patient who's undergone cornea transplant. And lastly, we'll have our moderator, Ms. Katile, who will take us through the session. So karibuni sana. Job.
Thank you so much, Elizabeth, for setting up this wonderful platform. As Elizabeth has said, my name is Joab Wako, and I am the founder of Transplant Education Kenya. And basically what we do, we raise awareness on organ donation, mostly solid like kidney and liver. And hopefully we want to expand the series, as Elizabeth has said, to include tissues such as cornea and other tissues that may help patients out there. So I'm very excited to hear about the cornea and to see how we can raise awareness, because I believe that is what we have in common, is raising awareness on organ donation and tissue donation. There are similar issues where a lot of the public doesn't know about them. So there are a lot of myths surrounding these two types of donations. So I'm very excited about this platform and looking forward to more. Asante sana.
Stephen, yeah, take it up.
Thank you, Elizabeth. My name is Stephen Rukwaro. I'm from Lions Site First Eye Hospital. So we are a hospital that specializes in eye care, started in 1997. So we've been in this business for about 23 years now. We have the first and the only operational eye bank in East and Central Africa that was started in the year 2000. So this is a center that does the harvesting, storage, analysis of cornea data tissue, and does the transplanting on patients who require it. So we also have Chris, who is on board, who is a specialist in it. So I'm not going to go into much details, but I am very excited about this opportunity and the work that all of us are doing in raising awareness about cornea donation. Thank you.
Great. Thank you so much, Stephen. Chris?
Okay, thank you, Elizabeth. My name is Christopher Bungala. I'm a cornea retrieval specialist from Lions Site First Eye Hospital. Probably specifically Kanubai Babla Eye Bank, which started in 2000, was officially opened in 2009. And since then, we've been doing cornea harvesting and analyzation. So this is a good opportunity to also showcase what we do. Thank you very much.
Thank you, Stephen. Timothy, kindly introduce yourself.
So, hello, I'm Timothy Minor, a recipient of the cornea of the grafts for both eyes. And I'm just here to also share my experience and how life has been with the new corneas.
Thank you, Timothy. We really look forward to hear your experience and learn more about it. And now I think lastly, I'll call our moderator for the webinar, who is Ms. Katile. She's the founder, director of Youth Barrier Breakers Africa. She'll be taking us through the webinar. So karibu sana Katile.
Good afternoon, good evening. My name is Katile. I'm the founder of Breakers Africa, and I'm so glad that Elizabeth brought up the topic of cornea transplant, and I hope we gain much. For all those who are joining, welcome so much. And I guess Elizabeth, you can take over and then I can moderate the session. Thank you.
Yeah, so start. You can start the webinar, Katile. Go on. The floor is yours.
Okay, thank you, Elizabeth, for such an introduction, and thank you all for the panelists who are on board. It's 16 minutes past time, and I guess we can start. We are also live in Facebook. I have shared the link in the chat box. I guess you can check. And then if you have a question, I suggest that you will do it on the chat box. You can write your questions on the chat box and the speakers go on. And maybe, oh, my voice is breaking, sorry. You can put your question on the chat box, and if you have a question, you can raise your hand. Yeah, we'll see it and then we'll tell the speaker to answer you. I guess we can start the session if there's nothing more. So our first speaker, I don't know the first speaker, Madam Elizabeth.
I think we'll start with Chris, who'll be taking us through some of the questions, or rather some of the guidelines that we sent to him. Yeah, he knows how he'll do the presentation, and then we'll take it up. Timothy will take it up and share his experience. And we're going to answer some of the questions that are going to come up. Yeah. So Chris, karibu.
Thank you, Sana. So first, we're going to go through the specific. I'll just go through the major eye diseases that we know. I hope I'm loud enough. The major diseases that affect the eye, aside from the ones which lead to cornea transplant. First of all, we can start with glaucoma. Glaucoma is an eye condition that is characterized by high pressures. We call them IOPs, intraocular pressures. Yeah. So these, when the pressures are above 10 and 21, they usually affect the optic nerves. Hence, you get your vision goes slowly from the peripheries. Then we have a cataract. Cataract is a common eye condition that is not an emergency really, but usually it's just like the normal cloud, it's the clouding of the lens within the eye. So with cataract, it's usually when the eyes, the lens is damaged, it turns into like it's whitish. So it's not an emergency. They usually remove the cataract surgically, and then they put a artificial lens, which you're able to see. So it's usually corrected, and you usually wait until it's mature enough, so in order to remove the cataract itself. So next, and the other one is the major one that we're dwelling on is cornea blindness. So cornea blindness is I'd say it's the decrease in vision due to cornea. The cornea, first of all, is the clear part of the eye. It's just like in a simple way, it's like your watch or your clock, the glass on top of the watch. It's same as the eye. That glass, when it's affected, you can't see through and read your time. So it's the same as the eye. We have a clear glass on top of the eye. That's called the cornea. So when your vision is affected due to that cornea, that's what we call cornea blindness. Okay. So there are different causes of cornea blindness. You can get through trauma. Maybe you got an accident and something hits you on the cornea, and then you're not able to see clearly. That's one. And then maybe the cornea is scarred, making you not to be able to see clearly. That's another cause. And ulceration of the cornea, maybe caused through by conjunctivitis. That's a allergy of the eyes. Yeah? It inflammates on the cornea, and then you're not able to see clearly. That may lead also to cornea blindness. Malnutrition. When we're speaking about malnutrition, you talk about vitamin A deficiencies. For example, if you're lacking vitamin A, and it may cause dry eye syndromes. Hence, your cornea could be affected in such a way that you're not able to see. Okay, we have other cornea disorders that may cause, like, for example, you get like keratitis. You get keratitis, and then your cornea get affected. That's a disease. You're talking about the diseases there. So keratitis is basically the inflammation of the clear tissue in front of the cornea. There's a layer of the cornea. So maybe provided you've been using your contact lenses for a prolonged period of time, it may inflame the cornea, hence causing keratitis. Okay, so that's one cause. That's the let me say the common causes of cornea blindness. Okay, the solution to cornea blindness, I'd say sadly it's cornea transplant. There are other ways that you can stop progression of your infection or your abnormalities. For example, when you talk about keratoconus is a condition where the fibers within the corneas, they might lose, they might thin out. They get weak, and then they start getting thin. When they thin out, they bulge. The cornea bulges from outside, hence affecting your vision. Whatever you're seeing is not able to be directed back to your macula where you're able to see clearly. So that the solution to only that is cornea transplant. There are other ways of maybe stopping that progression of that keratoconus. You can use hard lenses to stop progression of that cornea into stages. It's usually in stages. Keratoconus is usually in stages. Stage 1, 2, 3, and 4. So in the early stages, you can correct it from progressing, but it does not bring about the clear. It cannot affect the vision, the original vision. So you just have to do cornea transplant in order to get the perfect vision. Otherwise, these cross-linking surgeries and lenses, hard contact lenses, they only stop progression of the infection. Okay. So I'll go to types of grafts that are done. Basically, they are just two. The other ones are just sub graft. We usually have a penetrating keratoplasty. That's a full cornea transplant. When it's the whole layers within the corneas are affected, you just have to do a PKP. We call it PKP in short, penetrating keratoplasty. So in this, you just remove the whole cornea, and then you put a recipient cornea on top. You suture it after removing the affected cornea. And then the other type of graft, we have a lamellar keratoplasty. This is where you just remove the layer, be it the bottom of the top layer that is affected, and then you graft a good layer. So basically, those are the major types. So they are the two types of grafts that are done. And there are these other therapeutics, is just a form of PKP, and patch graft is just for in case of perforation, you just do a patch on top of the cornea. So we go to cornea harvesting. So I think this is the major part where I'm supposed to explain properly. Okay, cornea harvesting. Cornea harvesting is a process in which you retrieve the a donor cornea from the deceased body. So basically, it is done on a dead body. After one has donated and then and he is passed on, so we usually go and retrieve the cornea from that body within 6 hours. After 6 hours, the cornea is usually the cells within the cornea usually die. So we usually retrieve the cornea within 6 hours and put it on a preservative, in which it stays in the preservative for a good 14 days. After that, the media within the preservative usually expires. So after harvesting the cornea, we usually store it within a temperature in the preservatives and keep it in the freezer within a temperature of 2 to 8 degrees. So I'll go through the process on donation briefly, so that we get to know how it is done. Okay, first of all, for you to be a donor, there are specific, basically whoever can donate the cornea. If you have the deformities, let's say you had previous deformities on the cornea, you're basically ruled out of donation, because we cannot transplant, we cannot make use of a defected cornea, a bad cornea. Let me use that for lack of a better word. Okay. If you have keratoconus, the cornea is not perfect, so you cannot use it on transplant. If, for example, you have an infection, for example, you have a septicemia, such infection which can affect even the cornea and can be passed on to the recipient, you cannot donate. Age is not a number. You can it's not an issue. You can just you can donate either way, regardless, and then henceforth we can do the analyzation of the cornea. So on retrieving the cornea, we usually come within 6 hours to wherever you are and get the consent from the relatives. After that, after getting the consent, we can proceed on retrieving the cornea. We usually check on the blood, first of all, because of the key issue of what is required before we start harvesting. With the blood, we usually do blood screening later on. So if we don't get the blood, it means that the cornea won't help us, because we have to do screening on hepatitis B, hepatitis C, HIV, and syphilis. In any case, these results, if this test turns positive, we cannot utilize the cornea. So we have to start with the blood first of all. We have our own means of retrieving the blood, regardless how many hours the body has stayed. We can retrieve the blood, and then if we get the blood, then we can proceed on harvesting. Harvesting is done within, let's say, 10 to 15 minutes per eye. It's a quick procedure which is done anywhere. We usually harvest wherever the body. If you call us in your place at home, we'll come with the equipment and harvest it. If you call us in the hospitals, in the morgue, we usually go and harvest the cornea. Regardless, and we have to take the history of the patient. For example, to check before, we usually take the history before harvesting. So, for example, if you have we get on the call, we get such infection like cancer above the neck, we usually can't utilize the cornea, because the infection, it might have, we can pass the infection to the recipient. If somebody probably has malaria, septicemia, there are many infections that we literally rule out during taking the history prior harvesting the cornea. Okay, so we only harvest the cornea from the eye, depending on the visual. Okay, let me not limit ourselves from harvesting only the cornea, because we have other surgeries that require the sclera, that's the white part of the eye. So depending on the pledge, if you pledge the whole eye, we might take the whole eye, and you that's the sclera, the white part. There usually are surgery for that white part, the sclera, that we usually utilize in our eye bank. So if you've pledged to harvest the whole eye, we can go on and take and harvest the whole eye. If you pledge to take the cornea only, we'll only take the cornea only. So it usually depends on the pledge of the deceased and the consent of the relatives. Then after taking the cornea, we usually do a cornea analyzation. We check on the defects, on the folds inside the cornea. We use a machine called keratoanalyzer, which we check on the cell counts within the cornea. Basically, the normal cell count that you usually have to utilize the cornea from 1,500, let me say, from 1,500, we can do a therapeutic graft and utilize on it. And from 2,500 cell count, I'm talking about, we can do an optical graft. Optical graft is for the purpose of seeing. Therapeutic graft is a graft where we do just to replace the infected cornea as we wait to do the major surgery optical graft. So we usually utilize basically all the corneas, provided the screening is okay and everything else is okay. Okay, we are not limited to harvesting in any facility. We usually harvest from wherever. At the moment, we've done a lot of cornea harvesting in, let's say, Mpisha. Mpisha, we usually do several. Nairobi Hospital, Guru we've done. We're not limited to any health facility. As long as the patient is comfortable and the relative are comfortable on us harvesting from there, even at home, we usually go and harvest it from there. So, and currently we've done, let's say within our iBank, we've done around 200, we usually do around 250 grafts annually. So, and which is it's compared to other iBanks abroad, that's slightly quite slight small number. That's the lowest number done. So basically, we usually encourage people to donate so that we can clear the backlog. Because when you talk about the backlog, we usually see younger people are usually the ones who are in need of that cornea. From the age of as low as 3 to around 30, from 30 and below. So the list from there, we have like 200 patients waiting for cornea per surgeon. So it's usually on high demand, and we don't usually, when we get the cornea and we analyze, we get it's perfect. We usually don't. We don't wait until 2 weeks for it to expire. It's usually once it's okay, it's transplanted. So currently now, iBank, we don't have any cornea as backup for storage because we've utilized everything, and we have limited donors. The age limit for the people that we usually get corneas, let's say currently, are the elderly people, and especially from the Kenyan Asian community. They're the ones who are generous enough to donate for corneas. In Kenya, let's say, as these other communities, sub-tribes, we are limited by culture, and these myths. Those are the barriers that usually affect such donations. So if we can get to create awareness on SALS and break this myth, we can get even a younger cornea so that we can utilize on the younger people waiting on the list for cornea. I think I'm through. Yeah, that's that. Over to you, Elizabeth.
Oh, thank you. Thank you, Chris. I'm sure I have a lot of questions and I'm sure everyone else does. So if you have a question, kindly put it on the chat space. Then Katile is going to guide us on how we're going to do how we are going to answer this. But just a few questions for clarity. You've mentioned that consent, once the person or the deceased person dies who had already pledged to give their cornea, you seek consent from their family. So is it, no, tell us which one comes first? Like when you pledge, isn't that like giving consent that you've given your cornea, or do you require that consent from the family after the person has died? What's the difference and which one comes first?
Yeah, let me say that that's usually a challenge because if we check on the government, on the policies in Kenya, the body usually belongs when you die, your body belongs to your relatives, actually, the one, your next of kin, your immediate family. So
Okay.
you can't just go and harvest. You have to get consent from them for you to proceed. So it's usually a challenge. You can find many people donate, usually pledge before they die. For example, I've pledged before I die, but when I die, you have to get permission from my wife and from my parents or something. You see, so it's usually a challenge because it usually depends with their mood. If they that's the hardest thing with the Africans. We usually grieve, let me say, painfully. So for any reason they might deny that consent on signing, and then we just lose that corner. So it basically depends on the relatives.
Wow. Okay. All right. Thank you. And you said you encourage people to donate. Like, what are some of the ways that your hospital, like, do you have meetings? Do you hold such webinars? What are some of the ways that you encourage people to donate?
We usually just create awareness, and let's say we usually market. We usually go to media houses and try at least to create awareness on that. I think that's pretty much what we can do, but you cannot force somebody else to pledge or something. So we usually play our part on creating awareness on cornea donation. I think Stephen will talk about that, much of that part.
Oh, yes. Yeah, Stephen will be better placed. Stephen, are you
Yeah.
in the meeting? Do you mind telling us about some of the ways that you create awareness around cornea donation and transplant in the country as Lions? He was in the meeting. Yeah, no, I think he's left. I think he has left the meeting, but yeah, but that was a good answer, Chris. And
Yeah, I think.
lastly,
Mhm.
he's back? No. Lastly, could you please tell us what criteria do you use when allocating the donated cornea? Like, do you have a waiting
Okay.
list, and how do
Yeah.
you mark
Le-
this?
Okay, like I've said, we usually have a waiting list, but it's not like we usually follow the list on like compared to like I think in like kidney donation, I think they usually have a list or something in the United States. But then here we usually have a waiting list, but then the transplant usually depends on the age and the let me say the cells in the cornea. So it's not an issue of first come first serve. You can, for example, you can get a good cornea from a person, let's say a person from like a 75-year-old, and then the waiting list is full of young persons, let's say age between 10 and 20. Yeah. So when you check on the cell counts between these two age groups, there's a big gap on that. You might find the cell count from a 75-year-old is around um, let's say 2,400 cell counts. And then the younger generation, the younger people waiting on the list usually require a higher cell count in order for them to last them for like around more years. You see, so you cannot easily take a 75-year-old cornea and put it on a 3-year-old child. You see, because the child will need a longer lasting cornea without that fault. So on the criteria, we usually check on the cell count and the age group.
Okay.
So that's what we usually do. So you find on our list the people who are there are younger people in the list more than the older people, because they usually get donors from the older people, which can only utilize for like from 50 and above, 40 and above. See, you cannot transplant a 90-year-old cornea into a 10-year-old child. You see,
Yeah, true. And how
for lack of
successful
a
are
better
they?
word, actually.
Yeah, we get you. How successful at the cornea transplant? Like once you receive the transplant once, do you need it at a later stage in your life, or that's it?
Another cornea.
Yeah, will you require another one, or once you get it once, you'll use it for life?
Yeah, you can. It's hard for a cornea to reject. First of all, with a cornea, it doesn't have blood veins. It's usually a clear substance. So it's hard for it to reject. First of all, once you get a transplant, and if it's reject, you usually have drops. I think Timothy will talk about that more.
Okay.
But then we usually have drops that you put to prevent rejection of that cornea. Okay. And then so you can, it's usually effective. Once you get a new cornea, it's like you've gotten if like it's, for example, if like you had an opaque glass, let me say opaque glass, and then you get you remove the glass, you just replace it with a clear glass. You're able to see clearly, and it's able to sustain you for a longer period of time without rejection, unless you fail on putting on the drop, then or you get an accident, or you mismanage yourself.
Oh, okay. Yeah, those are my questions. Katila, maybe you can highlight some of the questions that people have for Chris. Karibu.
Hello, there's a question from the chat box. Someone
Okay.
is asking, Maureen, when it comes to spectacles, does it restore one's eyesight in the long run?
Spectacles, as in,
Glasses.
they are, I usually say a glass is just something that is used to correct myopia, the near and far sightedness of the eye. But then when it comes to cornea, what you have, it's a damaged cornea. So a glass can only can only help you when you have that near and far sightedness. But once your either your nerve is damaged, either your cornea is damaged, you'll just need a transplant. For example, it's like telling me there's a blind person, and then it's putting on glasses. Glasses will not help. You have to correct the real thing, the main cause of that vision loss. So with cornea transplant, you only deal with the things that you can deal with the transplant and maybe cross-linking to stop progression. But with cross-linking, you cannot get 100% vision. You still have to use glasses. So the only way you'll get higher percent chances of seeing clearly with cornea blindness is just getting a transplant.
Thank you so much, Stephen, for that. I hope Maureen is answered. We still have another question in the chat box from Josephat. Josephat Wandere is asking about those people with retinitis pigmentosa. Is the treatment option or corrective? Is there a treatment option or corrective mechanism for a person with retinitis pigmentosa?
When you talk about the retina, well, first of all, we have to see where the retina is located. Retina is usually located in the back. So with such condition, usually I usually leave them, especially the retina specialist, but then you usually get either injection to sustain, or you get surgeries on that. But then that may not affect the cornea really. I don't know, maybe to specify on the question clearly.
Josephat Are you answered? If you are not, you can unmute then ask
Yeah,
your question.
he can ask his question clearly.
Yeah, just what? Are you answered? Just what? You can unmute if you are not answered. Okay, he says he's answered. So we'll go to the next question from Rhoda Maragu. Rhoda is asking, can a transplanted cornea get infected?
Yes. A cornea is just a tissue. It's a piece of it's an organ. It's like I usually give a simple example. It's like you're going to shower. Once you're off the shower, you don't expect to never get to get dirty or something. Yeah. So it's like when you get that organ, you're still subjected to infections. So you can still get on that cornea. You can still get keratoconus. You can still get other infections of the cornea. It doesn't give you immunity to other infections. As long as you expose yourself to other infections, you'll still get it's just like a normal. It's a normal cornea, only that it's gotten from another recipient. But the cornea usually can get affected.
Thank you, Stephen. I hope Maragu is answered. We still have more questions. One question from Sharma is in like corneal donation is totally new subject in Seychelles. So it's asking for advice on steps to be taken to sensitive populations and what sources are needed to make it happen. Like what sources are needed for corneal transplant to happen. Yeah.
First, corneal transplant, you need a good eye facility, first of all, and you need a good surgeon for that. Those are the two major things you have to do. Because other than, for example, us, we don't usually rely on the local corneas. We usually get corneas from other eye banks, especially from Italy, France, and maybe USA mostly. So having a cornea transplant, what you have to do, if you have the surgeon, you can just import the corneas from other eye banks, whether they're available, because and then you can utilize them. For like in our case, we usually get corneas from other eye banks to clear the backlog in our eye bank, because locally we don't have enough corneas. People don't donate enough to utilize. So if you have a surgeon, you have a good eye facilities that you can do a good facility that you can do the transplant. And if the people are locally are willing to donate, you can just go for studies on how to harvest the cornea locally and do the transplants. I hope I'm clear on that.
Oh, thank you so much. I think it's just clear. I can see someone's hand up, Abubakar. Then we can give time to Abubakar to ask his question, and then we can go to the next speaker as other people put their questions in the chats. So Abubakar, you can unmute and then ask your question.
Good evening, everybody.
Good evening.
This is a very good educative presentation, as is very timely. I really enjoy it, or I'm enjoying it. But basically, I have just two questions. One is a question, the other one is an observation. Isn't the same thing with the hosts from the video? So can you correct that to put, please? That's one question. The second, this is an observation. His name is not appearing. What is appearing here is Elizabeth Bugwa. Am I correct in the spelling correct pronounce? Bugwa.
Yeah, it's
Yes.
So you have to change. We want to know your name. Or you have your namesake to the host. Are you namesake to the host? Because
actually
I'm seeing
Elizabeth, it's supposed to be Chris, yeah.
Yes, it's supposed to be Chris Mwangala. It's only that he joined using my link.
Oh, okay.
Yes. Yes.
My that's observation. The question I have: are you people going to give us certificate of participation? Zoom? Are you getting the question?
Yes. We're not in a position to.
You know, apart from the knowledge one will acquire, it will add something to one's curriculum by TO12 if we can have an online certificate of participation which one can print out.
All right. Thank you. We're going to consider that next time as we continue with the organ donation and transplant series. But for now, the webinar was only purposed for raising awareness around cornea transplant in the country, in Kenya specifically, because as Chris explained earlier, not many native Kenyans donate their cornea. So that's what we're doing today. We're just raising awareness, and that's why we have Chris here.
If you are raising awareness,
yeah,
most of us must have benefited from his presentation.
okay.
So I don't think it isn't out of place. If you can create a certificate, awareness is part of knowledge. We have gotten it like me. I'm by profession, I'm a social worker, hospital-based worker. So I think it's not out of place. Acquire quite a number of knowledge. It may happen to any.
All right, then we've taken that into consideration. Thank you. We're going to consider it. Maybe then now we can move to Timothy, who's going to share his experience and his story as a cornea recipient. Karibu, Timothy.
Thank you. I think for me, my journey with keratoconus. Does it sound okay?
Yes. Just carry on for like a minute, and then we are going to tell you.
Okay. So my journey started, I think, properly when I got diagnosed in 2007. I started wearing glasses and going to see an eye doctor. And I think through primary school up to 2010, 2011, when when I was seeing a doctor at Lions who had informed me that my cornea had gotten to a point of where it wasn't really functioning that well, because it was really noticeable. Even when I removed my glasses, you would notice that the cornea is bulging out. So the doctor at that time recommended that I get a cornea graft, which was mine was a full PKP, so that removed the whole cornea and give me a new one. So at that time, I didn't even know people could get cornea grafts and what really is to go, what is to involve it. So it was getting a new learning, but also learning something very scary for myself, because was 17. I was 17 at that time. So a teenager still, and I was like, okay, this is the doctor. The doctor wants to operate inside my eye, remove my cornea, give me a different one. So it was shocking. So my parents really held my hand and actually just allowed me to actually now go through with everything, get the operation done. After the operation, I think one of my best moments at that time was when the bandage was removed and I could see probably for the first time how other regular people how their eyesight is, and it was like it was kind of a shock because I was seeing things that the little things that I never used to notice, I never used to see. So that was my right eye. Then because the doctor advised I had to stay a whole year, allowing the graft to heal. And so after that, the stitches were removed. So that was between 2011 December to 2012 December. That was going through using eye drops, regular checkups to see the doctor so that they could make sure the stitches were okay. It was stressing because I was still in school. I wasn't allowed to be in. You could say I couldn't join other people doing other school events like going for games, sports, because any action that would or thing that would hit my eye that would bring complications to it. Then after my eye had healed, actually life went back to normal. I could see well. I didn't have any stresses. I even stopped wearing glasses. But then in 2015, around January, February, we just gone for regular checkup, and the doctor looked at now my left eye, which was ungrafted at that time, and the doctor just recommended that your other eye has now gotten to the point of where it needed a graft. So I think at that time I was a bit more confident. I knew what was going to happen. So it wasn't as stressing as the first time. So went in for my operation in 2015 for the left eye. It was done, healed, and the stitches were removed in the next year. So I think that's my cornea, my grafting history. Yeah. Over to you, Elizabeth.
Thank you, Timothy. Thank you for sharing your experience, even with the few internet issues. We could hear you. We've heard everything, and thank you so much for that. So I have 3 questions. One,
Okay.
in during your journey, did you come across any support group? Like, is there any support group for people who have gone through what you've gone through? Like, do you know other people who've gone through what you're going? And is there a support group for patients?
Okay. When I was getting my draft, there was actually none. But later on, I came and met some guys through lions who also had gone through the graft, and others who haven't. And we have a WhatsApp group where we talk, we share on our different journeys, the pains and sorrows of really not seeing at times. And yeah,
that's good.
because it's
sorry, go on.
Mm-hmm.
You were saying?
I was going to say, because we are guys, the condition I have is called keratoconus, and now we have different people who just try to come together and talk through the particular group.
Oh, that's really nice, because what I've seen in other organs like kidney, there's the Kenya Kidneys Patient Society, which is headed by a very good friend of mine called John Gikonyo. And what the organization does is that it brings people who have like new patients, and they talk to them, like they kind of support them and take them through the journey, whether they'll be on dialysis or whether they'll be lucky enough to undergo a transplant. Maybe you can think in the lines of um, uh, your support group, like talking about this, like sharing your experiences, and telling people that, hey, we were having eye diseases which would only be corrected using a transplant, and now we have the transplant and that has restored our sight. Maybe you can think around those lines, and yeah, just encourage more people to donate their cornea, and also to accept cornea transplant, because then again culture goes both ways. There are those who do not agree to donate, and there are those who do not agree to receive the tissues and the graft. The other question is, how long did you stay? Were you put on a waiting list, or were you lucky enough to for your doctor to tell you you require a cornea transplant, and we can schedule for one tomorrow because there's a cornea available? Or did you have to wait for one to be available?
So my first one, I actually had to look for a doctor outside Lions, because for me, my cornea really, it was at a point of kind of like at a point of no return. So I had to go to a doctor who had to import it specifically for me. But for the second one, I was on the waiting list. Then a cornea was found that was perfect for me, and I was called for it, and I went in for the surgery.
Oh, okay. Thank you. And do you need? I see you're wearing specs. Uh, are you able to see without them?
Yeah, these ones are more for the lights.
Okay.
Because I usually operate without them.
All right. That's beautiful. Maybe, yeah. Thank you for that. And Katile, maybe over to you. Do you have other questions?
Okay.
Hello.
Hello.
Yeah.
I think can ask about double vision in eyesight. Like what causes double vision and how is it corrected?
Maybe Chris can take that one.
Okay. I cannot. Am I clear?
Yeah.
Okay. Maybe okay. Double vision is in form of squint, or specifically which can the question be rephrased or something?
Double vision, like parts. Like a person cannot see because their eyes are facing the same side.
They are facing the same side. That's squint.
I don't
The
know the
same side,
exact one.
like the squint. If you're getting, probably I think that's more of squint. If it's squint, your eyes may be facing inwards or outwards. So that is basically, it's usually corrected by, we have a specialist who does that in our facility. That's just something to do with the eye muscles, he works on those muscles, how to tighten and to loosen on that muscles so that he can get the correct focus on one thing. So it can be corrected actually. But unless the question is referred, because that squint, I think he's talking about the squint.
Yeah, I guess it's that. And how long does it take to be corrected?
It's just a matter of you just come and you're seen, and then you're booked for a surgery. He knows which muscles are supposed to be corrected that are causing that squint. So it's not something that you're put on a list on correcting. That is just a surgery that you're booked, and then it's corrected.
Okay, thank you, Steve. I think I can see some question in the chat box from Facebook. And how do you differentiate a damaged cornea case and a short-sightedness case?
A damaged cornea, short-sightedness, when you come, okay, for example, with short-sightedness and let's say near and far sightedness, there are several tests that you usually do. You can do visual acuity. You can do visual acuity, and then after doing visual acuity, we can find what exactly is causing that short-sightedness or nearsightedness. But then with the cornea, the cornea practically is the clear glass on top of the eye. So we usually do a test called topography. Topography is usually aimed at checking on in a simple word, let me say the landscape of the cornea. So we'll know the cornea, whether the thickness of the cornea, we can know the deformity and the stage on which the keratoconus is. If it's stage 1, 2, 3, or 4. So we can know which one, we can know whether the patient requires a surgery to stop the progression of that keratoconus, or the patient needs a complete graft. You see, so near short-sightedness is more of something that can be corrected with either glasses or lenses. You see, depending on what the doctor prescribed. So that's that's the major difference between that. But you can still have myopia, you can still have that short-sightedness, and you can still have a damaged cornea, and you can still have glaucoma. You can have all the conditions in one eye because they affect different places. Like you can see glaucoma affects the nerve. It can cause your low vision. You can see like cornea, when the cornea is damaged, keratoconus affects the cornea, hence causing the low vision. So these are steps that we usually take. We usually do, let me say, screening on the hospital to know exactly what if it's myopia and what is causing exactly that low vision. So at the end of all the tests that we've done, we usually determine whether you are short-sighted or you have glaucoma, keratoconus, you're put in such categories. So there are two major differences between those two things.
Thank you. We still have another question from Facebook by Christy. He's asking, are there any technical problems you guys face while transplanting? And then another question, or rather, which innovative ideas can we actualize as biomedical engineers to make work easier? to repeat, like, are there any technical problems you face during transplanting, and which innovative ideas do you think like a biomedical engineer can do to make that work easier?
Or work of transplanting.
Yeah.
Transplanting is not an issue because there are already machines that are used to, or during transplanting. Let me start by what we harvest. We usually harvest the cornea with a white part. The white part is called the sclera. So in short, we usually harvest the cornea scleral button. It's the cornea, but the white plus with the white part of the cornea. So on transplanting, there are usually machines that are used to punch on the cornea, and then they are sutured on the host cornea. So I think we have machines to do that work, but the suturing usually done physically by the surgeon. So, and the other question was?
Innovative ideas that like a biomedical engineer can work on to innovate better ways to do the corneal transplant.
If we get, it always depends with the innovative machines that are brought about. So as at now, the issue we usually have, we don't have any challenges with transplanting of machines or something. The main challenge that we usually get is getting the cornea, the people pledging and donating the cornea. Because unless you're telling me we come with an artificial cornea that is made by machines, which is not possible. So we don't have any challenge with machines. We usually just have challenge with the cornea, getting the cornea itself. So machines practically, it's not a big issue as such because the surgeon usually do that work. Am I clear on that?
Yeah, I think that's fine. Maybe she was asking about, yeah, that artificial aspect, because I think it's not so complicated because there are not many rejections in corneal transplants.
Yeah. With corneas, we don't get rejections on because we usually put steroid drops. These are meant to suppress the rejection. As you put the drops, it will suppress the rejection until the cornea heals. And then the sutures are usually removed within a period of time. So machines are not that much of an aspect.
I think the question is answered. We can go to the next question from Yusuf. Ritwan Yusuf is asking if someone has a problem with allergy keratitis. I don't know if it's keratitis or keratitis.
Yeah.
What's the permanent treatment?
Sorry, come again.
If someone is suffering from allergic keratitis, what's the permanent treatment?
It usually depends with how severe the keratitis is. Keratitis can bring about can damage the cornea. So if it's severe and the cornea is already damaged, then the permanent treatment is getting a graft. If it's in the early stages, usually given medication to reduce the allergy, which might cause that. So in the early stages of in such inflammation or allergic reactions, we usually you're given drops to prevent more damage to the cornea and that itchiness. Because the more you rub your eyes, the more the cornea thins out. Okay.
So, like, what should that person does? Because Yusuf is saying that his friend is having the side effects every now and then it's so painful.
Is he self-medicating himself or because when you're having such effects, you have to come to be seen by a specialist, and then he'll prescribe the right medication to stop that reaction. Otherwise, with self-medication, you can put any drops and it can get worse, or you can even damage the cornea further. For example, you can put medication that can cause scars and further cause damage the cornea. So on such reaction, in case it's something you're far from a medical facility, we usually advise that once you're getting those allergic reaction, you're supposed just to wash running water on your eyes, just to reduce the reaction. But eventually you have to see a eye specialist.
Thank you. I guess the question is answered if there is no more elaboration on it from Yusuf. I can see him in the group. Another question from Vivian.
Mhm.
She would like to know whether there are ways of naturally improving one's eyesight, like other from using spectacles, maybe other from the transplant. Like, I guess it's how you can improve your eyesight naturally.
That's a general question. Aside from diet, basically, that's a general question. I don't know whether we are talking about the whole eye or just the cornea itself. But if it's the cornea, just preventing, with cornea, you just have to, whenever you get an issue, you have to come for checkup. Aside from other diets, you just keep your eye lubricated. You just know, okay, basically you just have to know your eyes well. If you're having dry eye syndromes, you know you need something, a lubricant to be putting that. If you're told you're lacking you're lacking any minerals, for example, you're lacking, you just have to improve your diet, and constantly, like at least twice or once per year, you have to come for an eye checkup. Because funny thing with the eyes, you can never tell. You can never tell. You can never know when you're sick how severe the infection or what you're having is. So the best thing is you coming for a checkup. For example, if you with the eye pressures, you can never tell whether the eye pressures are high. It's just a silent killer of the eye. You cannot know whether the pressures are high or on how far the eye is damaged. So you just have to come check for eye pressures. Whether they are high, you will be told, and then we just do screening for glaucoma. Otherwise, we're like more glaucoma patient, we usually find glaucoma patient in the end stages when the vision is lost on the periphery and they're left with the central vision. So coming for an eye checkup is something that should be done constantly.
Well answered. According to me, I can see only one more question if I'm not wrong. Joshua is asking, how long does the transplant take and what are the immediate effects and what's the cost for corneal transplants? How long the transplant takes, the immediate effects and costs?
Okay, the transplant, it usually mostly depends with the surgeon who's doing the surgery, but mostly I can say roughly 45 to 1 hour. One can do that. There are other ones who are faster, maybe 30 minutes, but it depends with actually how the process on which the surgeon does it and how fast he is. So it actually depends, but mostly from 45 to 1 hour. Uh, Cornea transplants are usually slightly costly because of the process of analyzing the cornea, regardless of the donation. Yeah? There's a long process on which we analyze the cornea. because we usually do the cell counting, we do the layer evaluation, we do the blood screening. We have to do several tests before certifying the cornea. So, and we usually even they're usually that's the surgeon that does the cornea usually charges. So it's usually slightly costly. Let me see, it's 250,000. That's per eye. But the cost, I usually say the cost is not that much of an issue, because with NHIF, NHIF usually covers most of it, almost I think the whole amount, and it's they don't delay on approval on the surgery. So NHIF covers most of that.
Katile, maybe I can ask, before you ask the next question, maybe I can ask for clarity there from what Chris has said about NHIF. Not that NHIF funds the procedure, and also you have the resources, the machines and the doctors. What now is hindering you from helping many people get the transplant and cure their disease?
That's it's simple, cornea donation. So you see, the problem here is not us doing the transplant, because it's usually catered for NHIF.
Yeah.
You see, and I usually say once your cornea is already damaged, it's not that of you cannot do anything. You cannot. It's not like an emergency unless it's perforated or something. So that's why there are people who usually are waiting for the cornea. You see, so the problem here is usually getting the corneas. If, for example, we get all the community to donate the corneas, then we could be doing the transplant. We can even do as much as even, because we have surgeons. Surgeons, we have like 3 surgeons. You see, so the what limits us is usually the cornea. We don't get much pledges. We don't people don't donate. As I told you, we usually rely on the Kenyan nation community. They are the ones who are not bound by myths and these vimila, let me call them. So we usually rely on them, and this limits us on the transplant.
And how many do you manage? How many do you manage to do in a year, even with this challenge?
Cornea. Like I said earlier, what we usually do like a 200 graft surgery in a year.
Wow. Okay.
Which is less. We're supposed to be doing like around even 800 or 500. So, and these among these 200, we usually do these are not locally harvested cornea. We usually compare to clear our backlog. We usually look for other eye banks to supply us with cornea. Actually, we usually get. So like getting a cornea from an eye bank from US, it's usually it's usually costly. So unless the same criteria we usually apply here is the same criteria they apply from on the other side. They have to get the age, and then we do we get the patient and then do that. For them to get even the cornea is usually a challenge.
Okay.
Yeah.
And who now caters for that cost if you're to source for this cornea from outside
We're the one
country?
who gets the cornea. The patient usually only pays for the surgery. We are the ones who request for the corneas. If they are there, they send out the printouts. We evaluate whether the cornea is valid for our patients, and then we usually order them.
Wow. Okay. Oh, thank you.
Yeah.
Katile?
Thank you, Elizabeth and Chris. I hope the question from Nyamoita is answered. So I don't know if there's someone who still have a question from the participants. If someone maybe has a question, you can unmute and then ask the question, because I can't see any more questions.
About this one from Joshua, the one that I've just posted, saying how long does the transplant take and what are the immediate effects? I think he means the transplant surgery, like how long it takes and what are the immediate effects.
During the surgery, the operation. You're talking about the operation.
Yeah, he says how long does the I think he means the operation and what are the immediate effects.
I think I already answered that. With the transplant, usually I said it depends actually with the surgeon who operates on it. So roughly the minimum may be for 45 to 1 hour. But then it depends with the ones who operate and how the eye is presented. You know, you can get another a complicated eye, so it might take a longer time, or something might happen during the surgery, so they have to take a longer time. You see. So and the effects during the surgery or effects to be specific.
I think after. What are the immediate effects? I think after the surgery, like what does the person experience?
Pain.
I think I'll I'll hand over that one to Tripoti. He's
Oh
a living
yes,
witness.
yes.
Usually after the surgery, you're going to be in pain, but the pain usually gradually eases. By the next day, you'll be better. The pain might be on and off during the week after the surgery, but after that, you can use your eyes just regularly. For me, my bandage was the bandage from the face was removed actually the next day, like the next day after the surgery, and I could use the eye.
Maybe
think,
Timothy, from what Chris has been saying and the questions that you've had people ask, is there anything you would want to clarify as a patient or talk about, expound on as a patient?
Mostly the stigma part. It's really hard for people who have had the graft to actually now come out and say that this is somebody's cornea in my eye, because you find people look at you and approach you differently. You have to kind of sometimes ease people into it, and it gets harder to share the more looks you get, like look at that person, look at that person, he has the eye of a dead person. So I think the stigma is still there, and it's now easing people to tell them that this is not me having just somebody's cornea. This is me actually having the regular eyesight, or normal eyesight, you can say.
We really need to address the stigma bit, and as I suggested to you earlier, maybe a good place to start will be your support group, the WhatsApp group, like you guys coming out and just even on social media, or reaching out to Lions, the Makina Chris, and asking them whether they can help you organize such webinars and even events post COVID, which can bring people together, and people can actually interact with you, and maybe this will encourage more people to become donors and to accept the corneas. Yeah.
I think
Katile,
even
do you have anything else from your end?
I think I'm just fine. I've gained a lot. If I just if anyone from the participant list has a question, maybe they can ask. They can unmute and ask. as we have more minutes, yeah, before we give the speakers time to say their parting shots. Yeah.
Okay, I think on it will be better for even Timothy to go ahead and tell the people and tell us how frequent the duration of time the stitches are removed and the number of stitches that he was done on. At least it's better coming from him. Timothy.
Timothy, I think we can get you. We can get you. Or am I the only one?
Yeah, you can.
Hey, Timothy. Yeah, we can't hear him. Do you mind answering that one, Chris?
The question that I've just asked.
Yes, because we can't hear him. I'll try and text him.
Okay. I wanted him to say it. I saw that question coming.
Okay.
So I wanted him to answer, but then it's okay. So
Oh.
basically, he's on.
He's answered on the chat. I'll read it out after you speak.
Okay, basically, the stitches are usually removed in intervals. It depends with the appointment that the surgeon usually does. I think a maximum of 12 stitches usually down around the cornea. So not all stitches are removed from at once. Usually, the surgeon usually examines the eye and removes them interruptedly. Like you can remove one up, another down. You can't just remove the whole stitches, all of the stitches at once. This is done usually in a period of time. As the tissue of the cornea heals, then you remove it. For example, you can even remove two and then do another two in a span of 3 months. So it usually depends with how the cornea heals. Okay.
Okay. And are there any marks left?
Morning.
Are there any marks left on the
Oh, you're
face?
asking me the question. I was
Yes.
distracted by that audio in the background. Okay. The marks usually heal with time also, because it's a suture which is removed. Yeah. So when it's removed, there's the tiny marks, but then you won't notice them when the tissue is healed. It's not like a scar. Because if the marks were left, it will even affect the vision. You see, it will be like a scar itself. So the marks usually heal. The stitches usually, after remove the stitches, it will heal clearly.
Okay.
Okay.
So Timothy says his stitches were 16 for both eyes, and it took 1 year. Okay. Sorry, 1 year to fully heal. And by saying 1 year, what does that mean? Like, does it mean pain was there for 1 year, or what does it mean?
Not the pain. It's not painful. Pain is usually for the first, let me say, for the first 2 days or something.
Okay.
Once after that graft. Okay. Like when you come to you're talking about the stitches being removed for that, it means that there are 12 stitches which are put. For him, in his case, there were 16 stitches that were put. So when you remove we usually remove the interruptedly in order to prevent the tissue from gaping. You understand?
Okay.
It's like if you remove for example, if you remove the board, all the stitches from the top side of the cornea where they sutured, it'll be open. It'll easily gape. So if you have to remove while skipping. You remove like the top and the bottom, side, within a period of time. So after 1 year, in his case, he's saying after 1 year, the tissue will have completely healed. And then probably all the stitches were removed and it's completely attached.
Okay.
But I know, I'm guessing he was still putting drops during that time to prevent further rejection because it's not completely healed.
Okay. Timothy, are you able to speak? Oops, sorry. I think your audio is still.
Okay.
Yeah. Speak again. I think we heard you. Oops. Sorry. Yeah, sorry. I'm really sorry. I know it's really disappointing at times. Katile, anything else from your end? Yeah. Sorry. I think we're also losing Katile. Yeah, thank God this is happening towards the end.
I saw Timothy.
Yeah.
So he could answer.
No, his audio is not working.
It's okay.
Yeah. So
I think we don't have more questions, and then you can give the speakers an opportunity to give parting shots. Maybe Chris, maybe we can have parting shots from you, and then we end the session.
And then I'm not getting you quite clearly.
yeah, Katile, your voice, kindly speak up kidogo tu. Yeah, I think she's also not audible. Yeah. So I think that will that should mark the end of our webinar. Having heard from a patient and a specialist.
Can I add one?
Yes, I was actually inviting you to do that, to add on something you feel is
Yeah.
very important.
Okay.
Yeah.
So I can go on. Yeah? So
Please,
basically, I didn't tell you on how to pledge. Yeah? We
Oh,
usually
yeah,
have, because that's the major thing.
Okay.
In case you want to pledge, we usually have forms. You can you can make your way to Lions to our hospital at Lions. You can get forms at the reception, and we can explain everything there. Still, we can still send you the form by our mail, Lions Ratio at ibank@lionsratio.org. And then we can still send you forms. You can fill, scan, and then send them back to us. And in case of any queries, we can still liaise via that mail address, or you can call Lions for that.
Okay.
It's not necessary. You don't have to have pledged. You don't have to have pledged before donating. So in case you have somebody that had already has passed on, and you still wants to you feel you want to pledge to give out his eyes, we can still call us, and then we'll come with the consent form directly. With that consent form, once you sign, we can proceed. It's not as in you have to pledge first, then consent, then we do that. So basically, that's that.
Okay, and you said you can be called and so that you can retrieve the corneas. Does that mean it can happen anywhere, or you have to take
Anywhere.
the disease to the anywhere,
We
even
usually
in your
harvest
house?
from anywhere. Mostly we
Okay,
can harvest it from the house. It depends where you are, where you're comfortable. If you want us to come to your place, we can come, and regardless of the time, we usually go. We are on 24 hours, and then we can come anytime. We usually work 24 hourly. Okay, so
okay,
when you call us, we'll come wherever you are. You just give us the direction. We come with the content form, and then provided you have the history, and
no
we
way.
can proceed. We can harvest from there. It's a sterile procedure, but we usually carry our
Oh
baggage and
boy, I
everything, our
think
gowns.
we've
So
we've
once
lost
we
Chris.
come, harvesting is not
I hope
bloody.
he's able to
Uh,
come back. We've
am I still on? We on still? You see? Are you able to hear me?
Please, it was a great session. And